Over to Dr. Kumar, doctor. He's a prolific refractive surgeon from Mumbai.
Good morning to you all, and thank you. I won't take much time. So, so I just got the Z8 in December, and I just want to share my little experience with this. So what is the advantage of the Z8? So if you see here, as far as the refractive goes, the therapeutic goes, and the cataract goes, it does everything. So you can do a Z LASIK, you can do clear, which is like smile, you can do pockets. As far as therapeutic goes, you can do intacs, you can do penetrating, lamellar, you can also do clear corneal incisions, arcuate incisions, rhexis, and fragmentation. So one unit can do everything absolutely. So that's the beauty of the convenience. If you look at it, this is the small footplate that it has got, and it can occupy in your OT. If you also look at how it is not temperature dependent. Some of the femtos need your air conditioning 24 hours. This does not really need that at all. It's very versatile. It's all in one. So you can see that it's a single person. You don't need two people to push the machine, and the whole unit can be pushed by one person. So it's very, very much mobile. In some centers in India, actually, it's being pushed from one place to the other, 200 kilometers apart. 3 doctors are sharing it in Punjab and using the unit every 2 days. I'm going to talk only on the refractive end of this in this session, LASIK flaps, intacs, and pockets, and I'm going to show only one video. And this is in real time, so there is no editing here. The first cases of my career of smile I did with Kudlu. I did 10 eyes, I think. That was a long time ago. This is my second case that I'm showing here, and unedited, okay? So I call it say clear with a smile. So they call it clear is corneal lenticle extraction for advanced refractive correction. This is how it is done. Dr. Bharti was the first surgeon to do this. This is, as I say, an unedited video. Centration is not an issue. So here what I've done, I've got 2 incisions. As you can see, one is for anterior and one is for posterior. So I've tried to shorten my learning curve. You can have 1 incision, you can have 2 incisions. So the right side is my anterior incision and the left side is my posterior incision. Now, as you can see here, I'm dissecting the posterior flap. As you go on the left side, it will only go posterior. If you go right side, it will only go anterior. So that's one part. Now, as far as the dissection goes, yes, we have to do the anterior first. But if you notice on the left side, I will not go all the way till the incision. So yes, I'm covering the center. Then I go right, I go left. But when I come left, I leave a little tissue near that incision. So I'm not separating the anterior cap completely, and there's a reason why I do that, so that it doesn't go down and my plane doesn't become difficult. So on the right side, I completely dissected it, and then I came out. Now I'm going posterior plane, right? Because don't forget the left side is the posterior plane, and that the same way I go straight ahead. So when the dissection of the lenticle actually happens, you will see some tissue separation happening at the level of the posterior plane incision. So you can see here it was straight posterior. We go straight ahead, a little to the right, a little to the left, and then take the forceps and remove it. So this is in real time, no editing, no fast forward, no slow. My second case on my machine. And then just take a forceps and then the lenticle comes out. So my experience is not as vast as people on the dais, but I've begun the story. And up till now, whatever number of cases I've done, I'm very, very happy. I'm still sticking to the nomogram that they suggest, which is thick cap of 130. I'm not going below 130 in my initial cases. So that was the ease of the lenticle removal. And I say, see clear with a smile. Thank you for your attention.
Thank you, Dr. Kumar. I think over to Dr. Ganesh.
Yeah, nice video, and being one of the first people, I just wanted to know, this is a high frequency femto. So the spots, what is the spot spacing?
That they don't give us the control like how you have the control. We only have control on energy to some level. We can't change the spot size.
But it must be a smaller spot size.
It's a nano.
Yeah.
And
so high frequency, smaller spot size. But what we see with smaller spot spacing is that the visual recovery on day one is not so good. Because now with the 800, we have an option. we can use a 4.5 or a 3 mm or
Yeah.
even a 1.
Yeah.
So when we use the 1, the dissection is very easy. It's
Yeah.
almost like a free-floating lenticule.
Yeah.
But the visual recovery takes much longer. The first day vision and the quality of vision is not that good. So that's what I was wondering, whether the quality of vision
So
is...
I have done 25 cases because I'm sticking to cylinder less than -1
Okay.
and a cap of 130. So I'm not crossing this. Except one patient where the flap actually folded and went in, then I had to actually struggle to remove it. One more thing I do is I don't wash, which may be wrong. You can advise me whether to do or
I
not
also
to do.
don't wash. It doesn't make a difference whether you wash.
Yeah, so I don't wash. So all of them were actually next day 6/6. Except this one patient where I struggled a little bit and that recovered over 2 weeks.
Yeah, 6/6 is, of course, your refractive correction, but the quality of vision.
Yeah, so we
look at
have
scatter.
started, so we have started doing a wavefront analysis and to
Wavefront
understand.
doesn't give scatter, so probably you need a HD analyzer. That's how we to
Yeah.
assess the interface. So
True.
that is something, because in the wet lab I looked at the interface and it was a little rough. So that's why
Okay.
I'm asking this. Whether
So-
because this is a machine, we want to know whether it's a jack of all or master of all. Because
Yeah.
normally a machine that does everything
Yeah.
does not do something, one thing very nicely. So
True.
that's something.
But at least what I'm saying is patient satisfaction is good up till now, except for that one eye which I struggled. Dissection was pretty okay. I think with experience this will get faster. So I don't think, up till now patients are happy, I'm happy. And another big advantage is the pack cost. Cost of the unit, which has to be more economical than what you guys are having.
Yeah.
And the pack cost is half. It's 21,000 for 2 eyes. And you're paying, I think, 44,000 for 2 eyes. So that is half the cost. So that's one big advantage. And of course, the CMCs and everything will be lower.
Thank you so much.
So, yes, you are right. What is, I mean, I don't know whether it's going to change long
So
term.
with his experience,
Acha.
such a long-term data,
Yeah,
so, I mean, the most important point is, at the end of the day, is what is the refractive outcome. Now, that is what is important,
Refractive outcome and quality of vision.
and quality of vision. So are you sure that, treating a -3 cylinder, ends up treating, making the patient immature? Because that is what is important.
So you're right. I'm not crossing the limit as far as the protocol goes, but there are places in Taiwan, there are places in Iran. Dr. Hashmi, I don't know, you might be knowing Hashmi. He has done more than 5,000 cases on clear. Taiwan has done 3,000 cases on clear. Vietnam,
Have cyclotorsion compensation and centration.
Mark. In my, but the new software upgrade, they are doing that. But right now, that's why I'm not doing over -1. See, I've limited myself, but they are doing everything.
Thank you so